Hi Manish, how are you?
Good morning, sir. We are excited to have you here at the Merrill Academy with your team.
Good morning.
We have 100 delegates from 19 countries. And with me on the panel, I have Dr. Ali from Sri Lanka, and Dr. Razmi from Afghanistan, Arshad from Malaysia, Moreras from Spain, and Panduranga from Oman. And the stage is yours, sir.
Good, that sounds very good. And Manish, welcome from Delhi. And as you know that this is from Batra Hospital, Delhi. This was the hospital I used to work for many years before I joined Fortis. And with me are my colleagues. On my right is Dr. Sanjeev Sharma, and on his right is Dr. Tahir. They're both senior consultants here. We got an interesting case for you. Dr. Sanjeev Sharma, would you just tell about the patient?
Yeah, good morning, everybody.
Good morning, Dr. Sharma.
This is a 59-year-old male with, this is a 59-year-old male with a history of diabetes, hypertension, and obese individual with a history of angina progressive since last 1 month. And one episode of respin 15 days back. TMT done outside was strongly positive. So then he was referred to us for further management. So this is the background of this patient.
So let us show you the angiogram which had been done a few days back, but we repeated it today.
Very good, thank you.
Can you start from the beginning? Yeah, show today's, yeah. So you can start seeing it. This is the caudal view. You can see, don't see much, there is some disease in LAD. Next. Now you can see the LAD is hidden behind the circ. Next. Yeah, that is the view. Can you just freeze it?
Very good. We see that very nicely.
Can you see the LAD?
Yes, we do see it, sir.
Yeah, so this is a long lesion and starts well before the septal. There is a severe disease before the septal, and then this disease extends into the mid LAD. Then there's a very tight lesion, and then there's a little bend, and then you can see can you run it?
Run?
Yes.
Correct. And you have an intermediate
So
size
this is
diagonal
the
coming
long
out.
lesion.
Yes.
That's right. And an intermediate size diagonal coming after the septal.
Yes.
So this is the target. His right is normal, and circumflex, as you see, is very dominant.
Very nice. So this is a radial case, I would imagine.
So next, yes. So we have done a little bit of work with crossing it with a whisper wire. We thought whisper will be a good wire for this because of the tortuosity and bends and very tight lesion. So we did cross it. You can see it being crossed. Next we put in a wire in the diagonal, which shot I think has not been taken. So we pre-dilating it with a 2 millimeter into 15 millimeter mosaic balloon from Merrill. And then dilating the proximal portion also with the same balloon. Okay, next. Now this is the picture, and then at this stage we thought let us do an OCT. Can you show the OCT picture?
And for the sake of our audience, Dr. Kaul,
Are
the
you able
reason
to
you selected
get-
OCT
yeah.
was over IVUS is because you were going to do BRS
I think
here?
we selected the OCT for two purposes. Yes. No, we're not going to use a BRS. We may show a BRS in the afternoon session. This we did to see the lesion length and the lesion characteristics,
Yes.
and also the vessel size, because there is a gross disparity.
Yes. So we see the
And what
OCT.
we see, can you see the OCT?
Yes, we do see it.
Yeah. So basically, you can see a lot of atherosclerotic tissue there with calcium, which was not angiographically visible, and according to the OCT, the vessel diameter distally comes to around 2.1, and the proximally it comes to around 2.8.
Okay.
We also did a measurement online, and we found that the proximal vessel is around 3.2, 3.3. So this is a classical case of a long lesion
Yes.
with obviously, because of the branches coming, a tapering vessel, because two vessels, the septal and the diagonal, have already come out.
A beautiful demonstration of how there's hidden calcium.
So
the
we
diffuse
thought that,
nature of
yes.
the disease, and also the length of the disease.
That's right.
All the information
Yes.
which you could achieve with the imaging device.
Yeah, so that is the utility of imaging device, although, from your day-to-day practice in such lesions, it's up to you whether you want to do it or not. But then, obviously, OCT shows you much more than is visible by a luminogram.
So will you do more vessel prep here?
So now our plan, yes. Yeah, we will do. We will do much more vessel prep now. I think we'll go with the 2.5 long balloon. Can we have a
15
2.5 millimeter balloon?
15, 2.5, 15.
Our aim basically is to stent the whole length,
Perhaps
and
this is
using
good
a
case for
long
biomorph.
tapering stent. That's
2.5,
right.
15.
So biomorph is the only stent which available in long lengths which are tapering, with the 0.5 millimeter difference between the proximal and the distal. And we find it a very good stent because it, number one, one does not have to use multiple stents.
Now, while we're
Multiple
prepping,
stents
balloon,
has its own drawback that
what will be your plan, Dr. Kaul, for the
Yeah.
diagonal? You're going to keep this as a provisional technique, I would imagine.
Yes, that's right, because the vessel size is not very big, so we will keep it as provisional technique, put in the stent and then see how it is, and in case something is required, we'll recross it, go with the balloon, dilate it, and then see. Most probably it won't require a stent, but we'll see.
Yeah, there's some times where there's a very tight ostial side branch lesion or pre-dilated before I jail the
Yes.
wire and stent across it. But in this case, you probably can get away without it.
So now let us,
Just check.
yeah, we'll come a bit proximal. Okay, dilate. This is what length?
15. 15.
So this is a 15 millimeter
8.
length balloon,
8. 8.
going to 8,
10.
10.
Okay, 12.
Okay. So now dilate it here.
Test. Test.
Test. Take a test before that, yeah. Yes, it's okay.
Test.
No, ठीक है. Dilate.
8,
Yeah.
10,
12.
12.
Okay.
Looks like
Let's
a
come
nice
to the
expansion here.
proximal edge of this. Yeah. Take a shot here. Let's see where is.
It's
Yes. Yes, this is the point we like to keep the stent. Yes.
8, 10.
Okay. Now we take out the balloon and see how good a job has been done.
Yeah, you probably need about a 45
Maybe we can give some
milliliter stent.
nitro. Yeah, so the stent size lengths come as 40, 50 and 60.
I'm going to ask my panel as you're working,
Nitro.
Dr. Kaul.
So let's give some nitro.
So, how do you approach this in Malaysia?
Yeah.
This is a typical bifurcation, long lesion. A lot of diabetes in our part of the world. How are you treating these types of patients?
Well, that case is a typical case of a bifurcation where I think it's going to have a nice way of. I mean, if we put a provisional stent, it's going to get open, almost sure.
AP cranial
You're
करना?
not gonna get too
AP
much
cranial.
with it, so
Distal spider में.
Okay,
I will do a
देखते हैं.
provisional stenting and with the bioman, if something happens, I
ठीक.
will
वहाँ तक
take
जाना
those
पड़ेगा.
violation. I think it's a very nice case to see that sometimes when you see the artery inside, you are able to identify things
Yeah.
that you are not able to see when you see that.
So I think we take a
It's
50.
interesting to see
Or
that
55.
how also the
3 लें,
the
3.5
side-
लें.
sides and to the side, the aesthetic.
Distal diameter देखो.
देखो method को.
Distal.
Yeah, I think I'll do something similar.
Lalit, distal
Basically,
diameter.
I'll wire down, wire the diagonal as in this case, and provisional stenting. IVUS, probably use IVUS, and in terms of it just needs good pre-dilatation, and then I use a single stent.
Okay, it looks like a nice pre-dill. It's a large vessel, Dr. Kaul.
Yeah, now we're just trying to, just measuring the distal. We now have to see whether we take a 3 into 50 or a 3.5.
3.
I think we'll take a 3,
3.
350. What is the length coming by the online?
Yeah, 37 आ रहा है.
Manish, what do you feel from there?
Yeah, I have to tell you that I think the prox will be 3.5, but I think a 3.0 is fine, 3.050, and then you can post-dilate the prox 3.5. So 3.0 is good.
Yeah, that was the plan, that you can always, because 3.5, 3 might be a little big for the distal side.
Yeah.
But we can always, do a OCT and, post dilate. That is an advantage in the metal stents. So let's take a
50.
350.
Dr. Manish,
Yes.
I always
So
have
the-
a dilemma.
By my, yes.
Some few of our patients have a septal larger than
3
even the diagonal.
Distal 2.5.
So
है
do
ये?
you
Distal
really
2.5.
protect it or you just...
Great question. This septal is a very important septal, a big septal. But because the origin is
2.5.
not severely diseased, I'm okay with
Distal
leaving it
कितना आ
alone.
रहा था?
If it had a severe lesion, or I had diminished after pre-dill.
3 फिर dilate कर लेंगे ना?
So the question, Dr. Kaul, from one of our panelists was, when do you wire septals this big? And if you ever do, if there's diminished flow and a large septal? I think it's a very good question, just like any side branch.
Yeah, we do see it often, but in this situation here, the septal has no disease at the origin.
Correct. That's what we said, yes.
And Yes, and so I will not protect it,
Yes.
but I have seen problems including bundle branch blocks and complete heart blocks happening very occasionally. And one patient I remember required a permanent pacemaker also. We tried to open the septal after doing the angioplasty, but I think the strut of the stent was sitting on the head of the septal and we just couldn't get in.
Yeah.
And that patient had to be given a pacemaker because he became dependent on pacing, temporary pacemaker. But those are very anecdotal instances.
Correct. No, that's just a discussion point.
Yeah. So now we're going with a morph. We were a little conservative. We're taking a 3 2.5 and we can always post dilate it. Because the distal vessel is is getting a little difficulty in crossing it.
Yeah, that's a tight lesion beyond it.
Yeah, I think we need to again dilate it.
Wait, 2.5.
Get the same balloon,
2.5.
Again, this is not uncommon. We see this regularly.
or else we need to,
This was what you saw on your OCT run. That
or
there was
else
some
we'll take
calcium.
a extra support wire by the side of it.
2.5, 50. नीचे.
We can take a all star, but first we'll dilate it. Get this 2.5 balloon. And also keep a all star wire ready. We can use a buddy wire. This is on the diagonal. No, go on. Dilate it here.
Probably a little bit of
Yeah,
wire
that is the
as well.
bend. Yeah. Dilate it to 12, 14.
14. 16.
Yes, deeply. Do it here. Yeah. See, there is some
Yeah.
not
Calcification.
opening it here. Do it here. Go high. Go high. 12, 14,
18,
15, 16, 18,
18,
20.
18.
Good. Let's see now. Now let us see how it goes. It is easier now. Now let's hope it goes, otherwise we go with a extra support wire. Get the stent. Get the same stent. Shabash. Yeah. What do you think? Will it go?
Yeah, it'll go. That was a
Manish?
little bit of- that was a little bit of wire wrap and pre-dill. So this is going to go now. I have all the confidence.
That is one of the downside of very long stents also. This stent otherwise is like any other biomime stent, that is 65 microns. Closed cells at the edges, open cells in the middle.
LED wire.
Let us see now. Not going.
I think also the wire you
Should
have
we
in the
pull the
rabbit is
diagonal
not
wire?
helping.
You have a whisper?
Should we pull the diagonal wire or
Yeah, why not?
this is a whisper?
Yes.
What I would do is pull the diag wire and put it down the LED as a buddy.
Yeah, good idea. Let's go to the RF caudal.
So what Dr. Kaul is going to do is put this down as a buddy wire, two wires in the same vessel. And all it does is it
Yeah,
gives you more rigidity for deliverability. The other thing I love to do, Dr. Kaul, I'm very conscious of what we spend. I also like the wiggle wire, which is ACS wire with
Yeah.
zigzags at the end and allows stents to deliver through tortuous and or difficult calcific long anatomy. The All-Star would be fine as well.
give a test.
खुला हुआ
Do a cranial. Or maybe let's take an all-star.
You'll get it.
Gone, gone.
There you go.
Okay. Now let's take the stent on the. We already have it. Still not going. Mhm.
3 NC balloon.
Yeah, so one option is to do a more aggressive preview.
Take an
with
NC
the,
balloon.
Maybe it should be useful to use a guideliner device.
Yeah.
It will give a lot of support to our minds.
And then there's the guideliner is a great friend.
312 NC
Everything
Yeah.
that adds up cost.
You have a guideliner here?
yeah
Guideliner? Let's dilate it first.
312 NC
3, 3,
3
3 NC.
15
What I would do, Dr. Kaul, in this case
Yeah, there's
is,
some calcium there, so
put the new balloon on the
Is it cut-
diagonal wire you put down the LED. Switch wires.
yes. Yeah. That's right. Put this. We can also use a cutting balloon. You have a cutting balloon here? Yeah. Let's first use a non-compliant balloon. On the diagonal wire, yes. Yes. goes easily. This is the point. Dilate.
6, 8, 10. 8, 10.
12.
12.
Okay.
Good. And go distally.
Distally, little lower pressure. There's a smaller vessel there. Yeah.
6.
Okay, that's enough. Do it here.
6, 8, 10.
Okay, deflate.
And now it'll go.
Let's try our luck now.
Yeah.
We'll go on the diagonal wire only.
Yeah.
The wire which was earlier in the diagonal, I mean.
Yes.
Okay. Let's put the stent in this.
Sister,
Come.
wet gauge.
We're noticing your LED wire is too far out.
No. No way.
Hey. Yeah.
Maybe some nitro may help.
Okay.
Gone. Gone. Let's take the other wire out. This is the other one.
एक मिनट देख लीजिए सर, कंफर्म कर ले.
Hmm?
एक डिस्टल देखो.
It's gone now. Now, which wire is what? Okay. Okay.
Yeah, wire.
वायर पे ही है ना? या
Approximately जा नहीं रहा सर, wire में नहीं है. Approximately. Yeah, this is different from the wire. Approximately different direction from the wire.
Tent wire.
Take a picture. Take a picture. Come proximally. Take a picture. All right. Is it okay?
Yeah, I think you're good there.
Yeah. Inflate.
Four, 6, 8, 10. 12. 12.
ठीक. Deflate. Take a picture. Bring a wire. Bring a new wire. New wire.
The only thing you have distal perforation because of the wire.
Yeah, you have an apical wire.
New wire.
New wire.
Hmm?
New wire.
Hmm. But the dye has disappeared.
Yeah,
It's not staying there.
it's probably in the LV cavity, but you should check that.
Yeah. Get a wire. New. Pressures are all right.
This is one of the problems with hydrophilic wires, like the whisper, especially when you lift distally. I don't like to keep them after I get them where I want to get them.
Yeah, okay. It's the loop. Loop के साथ चला गया. Loop के साथ चला गया.
निकालो उस वायर को.
Loop के साथ गया सर. ठीक है.
ठीक है ना?
Loop के साथ.
Okay. Take a picture now. Did you notice what had happened,
Yeah,
Manish?
yeah, we did. We were concerned about your wire
What?
distally.
Distal perforation तो नहीं. Echo. Echo. Echo लेके. Echo machine.
No, first let us optimize that.
So you have
Get a 3.5 balloon.
yeah. So you're going to need to balloon tamper.
You see what had happened is that yes, we'll do that. First let us optimize that result and then go to distal and tamponade that. You see what had happened, by mistake what had happened is that the wire which we pulled out was the wire which was through the balloon
Echo machine.
and through the stent,
Echo machine लेके.
and the stent, although in position, was without a wire.
Yeah, but I think the issue was that both wires were very distal.
So we-
hydrophilic wire.
फिर LED क्या? LED करिए.
Yeah.
Is this in the pericardial space?
So we
or is
deployed the stent.
Is this in the LV?
We're just doing an echo. Okay. Get
I doubt that this
get a
is in the
3.5
pericardial
balloon. Let
space.
us optimize the
3.5
proximal
balloon.
If it
result.
was, he'd be already hypotensive.
His cavity is filling.
Yeah, he's not
Cavity is filling
hypotensive.
automatically.
His
You may be lucky if it's just spilling into the LV
his
cavity.
tachycardia is there's no tachycardia. So what we're going to do is to optimize the proximal portion and then tamponade it.
So does everybody see the apical perforation of the LED? If it's right now, I wouldn't because it seems like it's spilling into the LV cavity, not the pericardium.
Yes, that's right. Okay, dilate here.
6, 8, 10, 12,
12, 14,
14,
16.
16,
Deflate.
8.
What size balloon would you like for the tamponading? 2 millimeter?
Yeah, I mean, I would be less concerned about doing anything
Deflate.
if I knew that it was going into the LV cavity. In other words, if there was no pericardial
Yes.
effusion,
Okay.
I wouldn't
Get an
be
echo.
worried.
Yes.
Inflating.
If there was, certainly I would just
10.
tamponade it,
12,
whatever
14.
it took
14.
to include it.
Stent boost.
I completely agree. I think that if it's go to
Yeah.
maybe we can
Can
wait
somebody
and see.
echo?
That's right.
Echo.
But taking care about what happened because
किसी को
sometimes
बुला लो.
Echo है sir, आ गया.
the patients go bad in the next 30 minutes. So wait a little bit
Yes,
and maybe that is enough.
and then make a decision.
That is the stent boost we're checking. Yeah, it looks good there. Meanwhile, we're doing an echo. Yeah.
How is the echo? The cardiac effusion is
12.
12,
minimal?
14.
Okay.
We're gonna find out. They're gonna do the echo now.
We're doing an echo. 8.
8. 8.
Okay.
The blood pressure
What
is
can you
stable.
see?
There's no pulses. There's no tachycardia. All these things.
Yeah, absolute stable.
consistent with
Heart rate is.
Within
this.
The LV
This
looks like
situation-
the LV.
Yeah.
ठीक है.
the situations
eight.
if perforation is occurring.
8.
So the
Eight.
first choice is
Okay.
to do the balloon in that area to keep it
It's in the
inflated.
pericardial space, yes. That's
Yeah.
what I would do.
If it doesn't work, then you should go for the coil closures, coil embolizations in the area.
You could do coil, you could do glue, yes. there are
11
different options, but coil would be the way I would do this. If this was spilling into the pericardium. Still, I don't think it is, but
If this is in
So
the
what do you
LV,
see?
it will disappear
No,
Anything in
within
pericardium?
48
No,
hours.
no.
yes.
There's nothing in the pericardium.
Okay,
4 chamber.
it's good
4
news.
chamber.
Better to be lucky than good sometimes.
So let's take a picture. Let's take a picture. Bring the apex. Yeah, taking a picture.
I think it's less.
So
It's either in the myocardium or inside the LV.
yes. So it immediately disappears. See, there's no dye now.
From the cavity.
The index lesion looks very good, Dr. Kaul, well expanded.
Yeah. So do you think we should go with a 2 millimeter balloon distally, very distally, and
I would say no.
it there?
I would keep the patient on the table for 30 minutes. I would re-echo
Yeah.
him. If there's no further effusion,
Yeah.
then I would stop and take
And
him
if
off
you
the
have echo
table.
है sir.
I would re-image him in 15 minutes. Keep him on the table with the guide in place.
Yeah.
And the wire
No
down.
fusion. No
can
fusion.
can you show them the echo? We'll show you the echo.
This should not be subtle because it's a large perforation. We need to have a subcostal view.
Of
Yeah, I
course.
think मैं कर लेता हूँ. I'll do. So AP.
आप कर लो.
AP. AP.
ठीक हो? He has no complaints.
Yeah, see, there's no fusion there. Is that
Blood pressure is 148. Heart rate is 80.
fluid? We can't see the echo well.
Patient doesn't have a pain.
Sorry?
Patient doesn't have
Can you
pain.
see the echo?
No, there's no symptoms.
No pain at all. No pain at all. Sleeping.
So most likely this is a wraparound LAD wire perforation into the LV cavity, which is
Yes.
fortunate. And
Yes.
usually these will
I-
seal and heal. But I would recommend keeping him on the
Settle
table
down.
and monitoring him for a period of at least 30 minutes.
And maybe during those 30 minutes
Yeah.
we could do a kissing balloon with the first diagonal that looks like it has a little low flow. And the flow has
The
happened.
question, Dr. Kaul, was about the diagonal branch. Was there adequate flow in the diagonal branch?
It's flowing quite well. Let's take a picture. Let's look at the diagonal. We could do something to this, but it's open, it's flowing.
Yeah, I mean, I agree with Dr. Morero's assessment that it's not unreasonable because it's nearly TIMI 3 flow, but there's quite a compromise that you wire it into a kissing balloon inflation. But again, if you touch it and you have a problem, then you have to be ready to treat it. So it's about a 225 vessel. The LAD looks spectacular, the index lesion. And so these are judgment calls. He's pain-free, the EKG is unchanged. You have an issue distally that needs to be managed.
Yeah.
So that would be a judgment call.
As it is a TB3 flow, the diagonal and relatively small vessels, still would you go for vascular dilatation in that case?
Again, that's the question is when do you do kissing balloon and when do you not? This is a provisional technique. The bottom line is that many of these type lesions are not physiologically significant.
Cavity में.
If this was my patient, I would probably do a gentle dilatation, but there's no right or wrong answer. In light of the fact that he has no pain and no EKG changes, I think it's okay if you didn't treat this.
I think that if we're going to wait for the
LED.
distal LED, and anyway, we could
Just
just
take a
wait for
picture.
the diagonal.
Yeah.
It might come, flow might be better.
Yeah, I think that's a great point. Especially if you're going to watch the distal perforation, you could take another picture and see how the diagonal does, and then you can decide.
Yeah. So that's what I think. We're just watching. If the flow comes down, we'll fix it.
Okay, we have about another
And we're
minute
just
of
watching
transmission
because his
time left.
pressures and everything remain still.
But I think it's these are the challenges of tough cases, and you managed it quite well. And I think this is going to be just fine.
Yeah, we had.
One more question here. As there is a small perforation is there, do you mind of continuing dual antiplatelet as usual dose? Yeah?
Yeah, you have no option here but to continue DABT. There's no issues. This is a fresh biomarker standard therapy.
Yeah, we will. Yes.
Questions from the audience? Yes.
I think it's an interesting case, but I have an opinion that leaving this diagonal alone at this stage, patient asymptomatic, no ECG changes, and we have some sort of a distal problem related to this perforation.
Yes.
I mean, and the patient hemodynamically stable, better
Yes.
to get him out of the table at this stage and then evaluate by the symptoms if there is
That's
anything
exactly
related
what,
to the diagonal.
I think that's what the plan is going to be. Yeah, it's a very good point.
But if the size
Yeah,
of
that's what the plan is
diagonal
going, not to, you know,
2.5 to
disturb it,
7.5,
yeah.
then even TV3 flow pinching like 99%, you have to intervene. The size also is very important, length and size of
course.
the.
Absolutely. There are many factors, but the size.
This
being-
looks to be 2 or less than 2 size.
It's probably a 225 roughly. Yes, Dr. Lee.
Sir,
Yeah, it
good
looks,
freeze frame. Actually, my point is a little
looks like a
proximal
2-2.
thing. The freeze frame is exactly frame to weight point. I find the proximal stent a little overhanging. It's looking, I don't know actually luminogram, because they have an OCT, they can go up and if required, see whether it's actually opposed. It's looking on the
Yeah, we'll go
luminogram
an
that its
OCT.
proximal is a little overhanging.
We're going to
Not
do
on
an
that.
OCT.
Yeah, I think that's fine. I understand.
No,
that.
since we have time, we're going to do an OCT.
Very good. Okay, and then we'll leave you after the OCT.
We have the OCT yes, we got the OCT caster already open. Okay, let's do a quick OCT. Are you ready? Yes, yes, get there. Bring it forward. Put out. Okay. That should be enough. ठीक है? Yeah. You take a lot of contrast. Okay, ready? Not getting it? थोड़ा सा पर्च कर दो. Okay. Yeah. So show the position of the stent. Yes. Yeah. Can it be shown to the audience there? It looks very well opposed. Let's come from distal to proximal. Okay.
Dr. Kaul, we don't see the OCT.
Please show it to the. Can you show the OCT image there? Just one. Give us 20 seconds.
Yes,
can
now
you
we
see it now?
Yes, now we see it. Beautiful. This is the 3D view. What happened?
Yeah.
Very nice. Well opposed. And a nice landing.
So that way it looks good. Can you show the inflow? You think it needs something there? Inflow.
Distal. But proximal.
Here. Inflow. Yes, here.
Is that a dissection?
Is there a dissection at the proximal? Just below, before that? No, before the proximal end. Yes, here. Come to the unstented segment. Proximal. Yes.
Right there, you see a flap?
Just a blood spill, nothing else.
This looks like some blood stream there, no?
Blood spill, nothing else. Artifact. No. I mean,
Take an LAO caudal and take a look.
see caudal.
Otherwise,
Yeah, let's take a LAO caudal, let's take angiographic views.
There's
otherwise,
a diagonal prior, no, also?
otherwise everything else looks quite good. Well explained. So Dr. Kaul, after this particular picture, we're going to leave you. We're going to thank you and your team for
Yes.
a beautiful demonstration. This last OCT is magnificent. Shows some
Well, it looks
difficulties.
all right.
It seemed like a straightforward case.
That is the, yeah.
We still see the OCT. We don't see your angiogram.
Show the angio. Can you see the angio?
Yeah, we see it now. Maybe just a little malopposed, but I don't see any dissection. The patient's
Can you do
doing
an
well.
RAO caudal? Yeah, patient is same blood pressure, 140, 76 rate.
Coronary sinus में.
So that was it.
Okay, I mean, I think that potentially you probably can leave that. The patient is doing well. It looks like it's emptying into the coronary sinus, unless I'm wrong.
That's right. The last picture.
Coronary sinus.
And we want to thank you for your transmission, and we will bid you goodbye. Thank you very much.
Thank you.